I do want to, we'll give some reminders in a second in terms of what we're going to be doing for the rest of the day. We're going to pull up some information about questions. First of all, if you have a question, you can use the poll everywhere. The link to that or the website to put in on your phone or computer is at the top there, the pollev.com/RMH 2026. You can also join by text. So sending RMH 2026 to the message 22333. That'll sort of log you into the poll everywhere system, and then you can submit a question anonymously if you would prefer. You can still ask a question in person anonymously too. You don't have to tell us your name necessarily, but if you want to use a microphone to ask questions, that would be great. While we're thinking of questions or logging into Poll Everywhere, just a couple quick reminders. So first of all, we have a really great, I'm biased, but I think we have a really great agenda for the rest of the day. We have some multidisciplinary sessions coming up on IBD and pregnancy. After lunch, we'll have a multidisciplinary session on managing hepatorenal syndrome. And then we'll close with a variety of GI topics this afternoon, including, so we started with the esophagus. I think our final talk of the day is on constipation. So I think that's fitting to start and end the day for a GI course. So questions are coming in. My stalling worked. All right. So it's a couple of questions on Wilson's disease. This is for Dr. Rice, obviously. So after someone has transplant for acute Wilson's, is that curative? And do they still need to follow a low copper diet lifelong, et cetera? Can it reoccur?
It's a great question. And these are on, yeah. It is curative. The enzyme, the ATP7B, comes with the new liver. I actually had this question from a family member of a patient who had acute Wilson's, if they're at risk for neurologic decompensation after the transplant with the new enzyme. But there's not really any literature on this, but it does not appear that the body, basically the new enzyme just does things correctly. So while we don't try to transplant everyone, it does cure a lot of things, specifically this. So great question. And there's no gender prevalence for Wilson's disease.
For Dr. Menard-Katcher, how do you handle patients with classic EOE symptoms, but borderline eosinophil counts on biopsy? Do you repeat endoscopy or treat based on the whole clinical picture? And I was going to ask a related question, I guess, just how do you think about histologic remission versus symptom remission? So it kind of goes hand in hand with that question.
Yeah, that's challenging. I think the important thing to note is, we say that it's 15 eosinophils per high-powered field is the diagnosis of EOE, forever shall be, forever will be. That's a completely arbitrary number, right? If you talk to a pathologist, their nightmare is counting up to 173 eosinophils in a high-powered field. And so I don't think there's a big difference between 15 eosinophils, 19 eosinophils. It really just, it's one or the other. It really doesn't matter. And so when I think about discordant or borderline, it's really what's going on. If I have a patient who has repeated food impactions, asthma, atopic disorders, and they have 14 eosinophils in the biopsy, I'm assuming I missed another part of the esophagus that had 19 or 20. And I'll just make that diagnosis of eosinophilic esophagitis and start on treatments. Whereas if I have someone who has globus, their endoscopy looks completely normal, and they're 70, then I might ignore 16 eosinophils or attribute that to some degree of reflux. And then Avash, don't take it personally. I completely forgot your question.
Remission versus symptom.
Yeah, and so there's a well-known discordance between symptoms and histology in eosinophilic esophagitis, and so it can be challenging to gauge improvement. When we think about this, I can dilate someone's esophagus as a glorified plumber. All I did was make tube wider, and their symptoms will improve dramatically, but I haven't done anything to change the underlying disease process. And so one of the things is if you get histologic improvement, but not symptoms, then that's when you're really looking for subtle or missed strictures. I'll just end, because there's other questions, by saying one of the areas that I see strictures missed a lot is I'll see someone have a balloon dilation in the lower esophagus, but you can miss proximal strictures really easily. When we do endoscopies, we blow by the upper esophagus, it can miss a significant narrowing. And so, my nursing team knows this, Kelly knows this, but I use a lot of savory or bougie dilations in UE because then I'm getting the entire esophagus.
Thank you. By the way, thanks for our AV support as well, for helping set up this poll everywhere and keep the questions in order here as well. So next question, Dr. Bhalla, is there any association between cannabis use and pancreatitis/chronic pancreatitis?
Yeah, there is. And there's kind of, I do counsel a lot of my patients on stopping marijuana, but it's also kind of choosing your battle with them and kind of what the concurrent use of alcohol and cigarettes are. Acute pancreatitis can be caused by cannabis and cannabis related products, but then you'll have a lot of patients that are also using cannabis to help alleviate their symptoms. And so deciding between that is really tough. And, when I see those patients in the beginning, my big takeaway is, hey, what are the battles we're going to fight first? And if there is concomitant alcohol and cigarette use, we kind of start with that first and then move to marijuana. And then also gauging how hesitant they are. But I do counsel on getting that to stop in all of our patients, because there is an association for acute and chronic pancreatitis. Do you want me to answer that celiac plexus block while we're there?
Yeah, sure.
And so, yes, there is a role for celiac plexus block in chronic pancreatitis patients. Again, making sure they're off alcohol before we start this, because that can sometimes contribute. The data behind celiac plexus block in terms of its benefits can be anywhere from several weeks to ideally 3 to 6 months. And sometimes you have to try to repeated block. But I do set the stage with patients that this may not solve all your symptoms and won't get rid of your pain 100%, but can help in reducing the amount of pain medications that you do need.
Thank you. Dr. Steiner?
There's plenty coming in. I'll hold mine. But if anyone wants the microphone, let me know.
I think there are some lower on the list too, but we can start from the bottom of what I can see here. Dr. Wieland, so for MASH, is semaglutide your first choice, or is it used if side effects occur with resmetirom, or do you use them both? How do you?
Yeah, it's very patient-centered. I will say in our MASH clinic, where I had an endocrinologist paired with me for many years now, up to over 50% of our patients were already on GLP-1s. And so if the first step is kind of making sure their diabetes and their metabolic management is optimized, and a lot of time there should already be a GLP-1 in that. So on average, it's really adding in the resmetirom when that's been optimized. And, if they're a candidate for Wegovy and they need weight management, that's going to be, my go-to. Honestly, a lot of it is dictated by insurance coverage. You're going to say, I have 2 good options here. I'm going to, pick what I might do first. We're usually not allowed to do both at the same time. I've tried to do that, but most of the time you have to kind of do it sequentially. I wouldn't do both the same day, but I've wanted to add in resmetirom when somebody's got clear ongoing lab elevations and high CAP scores. But I was thwarted by the insurance company making me wait this official 72 weeks of a GLP-1 trial. So there's a lot of factors that come into play. And at the end is it's very patient-centered, and we have a little bit of a shock and awe where we'd probably just put everybody on everything and then de-escalate once you get them down. But it's made it kind of an interesting and fun thing where we kind of do have to, you would think it could be this easy algorithm, but there's just a lot of complexities when you're actually the patient in front of you.
Great. And thanks for all the questions, by the way. Can steatosis be symptomatic with pain, and do you only see patients in clinic for steatosis when labs are abnormal, or do you just see whatever shows up on your schedule?
Short answer, I see what shows up on my schedule, and you never know what it's going to be. At one time, it was somebody who thought they were getting an EGD that day. But basically, the steatosis, most patients with hepatic steatosis don't have significant pain. If you really tease it out, a lot of them have this kind of vague, dull pain. So I definitely validate that yes, that is probably from that. If they're going into an emergency room every week, I'm like, you should probably have somebody make sure nothing else is going on. And then I send in my GI colleagues to make sure that that's being thoroughly assessed. But I definitely validate some pain. The other part of that question, do they have to have elevated liver tests or just, steatosis on its own? A fair amount of mast cell, even with fibrosis, have normal labs. So it's really more triaging and deciding on who is at risk for fibrosis and doing the non-invasive testing with like a FibroScan. It used to be FIB4 is still a really good tool, but the newer guidelines actually suggest that all diabetics are at high enough risk that it's actually reasonable to screen almost all diabetics for at-risk fibrosis.
Great. And then you described exciting treatment outcomes for the sample fibrotic patient with resmetirom and semaglutide. Is there a study using a tandem treatment of these medications and potentially reversing cirrhosis?
Overall, yes, there's a lot of combo therapies out there being studied. So as far as, we've in the world of mast cell, there's been a lot out there for a long time, and there's a lot of things that failed to get here. So it's hard to know what's actually going to really come to fruition. But I think probably using the combo would actually have even more benefit because you're hitting multiple different mechanisms. Because most of these patients probably have their metabolic syndrome and then some other hit. And ideally, we would know all the genetic factors that come into play and be able to tailor, but I don't envision that's happening anytime soon. But I think these combo therapies, I think, are the future to have the most effect at reversing fibrosis.
Dr. Wieland, we'll give you a break, but we're going to come back to you shortly, as you can see. So, Dr. Bhalla, do you think pancreatic steatosis has a role in chronic pancreatitis and should eventually be reported routinely on abdominal imaging, or is there not enough evidence that that changes management?
Yeah, it's a good question. We actually don't know what to do with pancreatic steatosis. And it does come up on imaging, and I think we probably have been not commenting on this for a very long time, even when we do EUS. It's very hit or miss on if this is commented on. There are some studies that are being done on a smaller scale to look at this from a cross-sectional imaging and EUS standpoint. I mean, what's interesting is we actually don't really, even on EUS, haven't had clear guidelines and standardization for pancreatic imaging on EUS, which the guidelines only came out about a year ago. From ASGE. So I think there's a lot of work to be done. There are some concerns that pancreatic steatosis could be a potential risk factor for pancreatic cancer and potentially even chronic panc as we move forward. So I think this may be one of those subtle findings that we may have to monitor more frequently, just like we are in situations like steatosis in the liver. But we don't know what to make of it. But I do think that, yes, it would be helpful to know. The question is, what do we do about it? Right now, nothing. But I imagine in the next 5 to 10 years, we'll have a lot more to be said on this topic.
Thank you. Dr. Rice, should checking ceruloplasmin in a serologic workup for liver disease be limited to a certain age range? I know you mentioned a little bit about age in your talk.
I actually looked this up recently because I was teaching some of the fellows about these cutoffs, not cutoffs, but ranges. And I think there's actually no guideline or evidence towards certain, other than it's uncommon. I personally don't order it above a 60-year-old. I think in the 50s, I will order it sometimes if it's like someone who are calling fatty liver disease with no risk factors. Obviously, there is lean MASH, but or someone who has other, like just family history, obviously, or other things that would point from a lab-wise, like a low alkaline phosphatase or neurologic symptoms. So I cater that population, but under 40, I think you can order it willingly because it's the high risk for it category. Above 60, I really don't order the test unless I really truly, I guess, above 60, I don't. 50, I just need to know that I'm going to get a uric copper if it's low.
Yep. Thank you. Recently, the last patient I diagnosed with Wilson's disease was 56 and confirmed on biopsy and genetic testing. So it does happen, but not as commonly as a young patient, obviously. So back to Dr. Wieland to, I think, close out the session. So 3 questions here. Okay. First, what role does either surgical or endoscopic bariatrics have in managing mast cells?
Yeah. Overall, I think it has probably a role that's underutilized. If there's cirrhotic and borderline hypertension, no, we probably got to do other stuff in those patients. But the data really suggests that in certain individuals and it's especially in somebody who doesn't want to be on medical therapy long term, there's a lot of people that prefer to like de-escalate the amount of meds they're on. So as we add more and more on, so I think we still continue to refer patients for that. And I need to do a better job of actually getting them to my colleagues that can do that and assess for that. But I think it's underutilized. And in the data, this idea of reversing fibrosis, I think the first model in MASL where we saw that was actually post-bariatric surgery, and up to like 40% went from like advanced fibrosis down to minimal fibrosis in a few years. So it's an undermet tool that we should continue to think about in well-selected patients.
And do you keep patients on resmetirom indefinitely?
That's still unknown. When I'm adding in these medicines or talking about the options with patients, with resmetirom, I tell them like this is something. Some of them want to stay on something. Some people like want to be on a med that fixes something, but I tell them this is like a long-term thing. So I set the expectation they may need to be on it, but we don't really know. And so that data, as far as long-term and kind of what we're doing, is still awaiting, because these are all new as far as them being only approved for a few years here. So I set the expectation they may need to be on indefinitely, but I don't tell them they have to. As opposed to the GLP-1s, the data really suggests that for that, they're gonna likely rebound from all the other factors. So that I set an expectation. This is something you'll probably need to stay on unless you want to try bariatric surgery. And then that might be a more sustained stay off medicines approach.
Awesome. And then lastly, Dr. Wieland, by the way, Dr. Wieland is a former course director for this, for Rocky Mountain Highlights, and has given many talks at this course about MASH. So this is probably a question you got a lot many years ago as well. So any role for vitamin E in the management of MASH?
Vitamin E, the Pivens trial many years ago, and some of the, when they looked at the meta-analyses, it just didn't do enough. It really didn't meet those endpoints that the FDA mandated. So to me, kind of risk benefit, I don't usually use it a lot in patients. In a well-selected patient, non-diabetic, if I really think they have MASH, I'll offer it and see if their liver tests improve or things improve. But I honestly don't reach for it very often, especially since we have these new tools that have really been shown to impact things.
Great. Well, thank you all again. Round of applause, obviously, for our first set of speakers. Really loved how engaged everyone was in terms of asking all of those questions. I thought that was a great first session. On your agenda, the second session is supposed to start at 9:50, but what we'll do is we'll start it at 9:55. That will give you enough time to have a break here. Feel free to interact with any of us. And most importantly, in my opinion, please visit the exhibit hall during your break as well. If you visit 12 or more booths by 2:45 and get your bingo card filled out, then you can be eligible to win one of 10 $100 gift cards. Gotta practice saying that. See you at 9:55. Thanks.